Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. We are going to talk about a topic that comes up in my medical practice virtually every day. I cannot tell you how many patients say to me, and I have random people that they're very interested in finding out. They're not even my patients, but they email me and they all have the same concern. I have a family member, a mother, a sister, a grandmother who had breast cancer. And they were told in no uncertain terms by their doctor, not by some random friend or they just even heard it on the internet. Their own doctor said, you can never take hormones because of this family history of breast cancer. So I want to set the record straight. There is a potential to have a higher risk of breast cancer based on family history. So this is important to know because risk doesn't mean destiny. It means what can you do to lower your risk and to prevent some bad outcome should you be the unfortunate person who develops breast cancer. Well, let's talk about the actual risk. If you have a first-degree relative, that would be a mother, a sister, a daughter. Those are first-degree relatives who have had breast cancer. Your risk, statistically, is doubled the average population of women age-matched. So that's significant because I am not now or ever have or ever will belittle the significance of breast cancer. Breast cancer kills about 40,000 American women every year. It's a significant cause of morbidity, which is problems that don't lead to death, and death itself. So way more women are diagnosed with breast cancer than actually die from breast cancer, but women do die from breast cancer. There's no question about it. And it is a very horrible thing to have to suffer from or lose a loved one or friend from breast cancer. So that is important to know. So I want to do everything in my power to lower everyone's risk of breast cancer. So knowing that if you have a first-degree relative who's had breast cancer, that you have a doubled risk matters. If it is a breast cancer that occurs before menopause, the risk is even higher. What if you have two first-degree relatives? Say you have a mother and a sister. Your risk may be as high as 5 times the average risk. So there's many permutations, but definitely the more relatives you have, the more risk you have that you will get breast cancer. And the genetics are complex. And by the way, I have many patients who have family members and they've had very comprehensive genetic testing and everything is negative. So what does that mean? Is it a gene we have yet to discover? Possibly. Is it some other environmental factor? Definitely, that is a possibility because we do know, and we're going to touch on it, that environmental effects can actually impact carcinogenesis within someone's body. So genetic testing is way more complex now than just looking at the BRCA1, the BRCA2. That's what most people know about. But so many more genes have now been investigated and found to be associated. So I want you to know that if you have a family history of breast cancer and you were tested and maybe you had some online test or you had testing many years ago, or the relative had testing many years ago and they say, I'm BRCA negative. That doesn't mean you're negative for the other genes. And I'm not going to go into all that right now because I don't think most of you are geneticists. So it's not really important for you to know all the different types of classifications and types of genes. What you would want to do is see a qualified geneticist and get good counseling and get proper testing. And if you have certain qualifications that are deemed making you an eligible candidate for insurance coverage, then such genetic testing is covered by insurance. If you don't meet the insurance company's definition of being qualified, then you have to pay cash. It's not that expensive anymore. You can get through my office, and I'm sure other offices can work out the same arrangements. You can have very comprehensive testing for about $300. Formerly, just doing BRCA testing was $3,000. So don't be afraid to just pay the bill, because you don't have to repeat the test if new genes aren't discovered. If you need to be retested, then because we find new genes and you tested negative and you want to know, especially if you have daughters, then you should get retested. So it's important to know all of that. Now, what about if you have a family history with or without any genetic testing that shows up positive? What do you do? What about these doctors who are telling patients, women all over, you cannot go on hormone therapy if you have a family history of breast cancer? That is not facts. That is not supported by data. This is so important. We have now had some recent studies that have really looked at the role of estradiol and even other estrogens that aren't estradiol and breast cancer. A recent study that did a meta-analysis and looked at only controlled studies. So it wasn't looking at studies that looked at just observation. These were all controlled studies, and they evaluated all of them, including the infamous Women's Health Initiative. What did they show? They showed that the earlier that you start estradiol or other estrogens, the lower your lifetime risk of breast cancer is. Exactly the opposite of what so many doctors are saying. Estrogen, and unbelievably, any estrogen that they used as a menopausal estrogen replacement, showed a reduced risk. Now, what kind of reduced risk? Well, about 1/3, like 33% reduced risk. In some cases, it was, depending on the study, it was 37% reduced risk. Overall, 35% reduced risk. So somewhere in the neighborhood of 33 to 37% lower chance of getting breast cancer if you were treated with estrogen in menopause. And as I just said, the earlier you started, the better. Now, what about progesterone? The data is more blurry because so many different progestins have been used. In the Women's Health Initiative, which was a gigantic study that I always say bad things about because it really destroyed so many women's lives, as far as I'm concerned, by making so many women and doctors afraid, literally like to death, to prescribe hormones or to take hormones, no matter what kind of hormones they were. Well, even looking at the Women's Health Initiative data, as I said, they use conjugated equine estrogens. The brand name for that is Premarin. In the women who'd had a hysterectomy, they showed a lowered incidence of breast cancer. Now, what about the progestin that was used, medroxyprogesterone acetate? That is the culprit. That is not real progesterone. It's a mimic that acts as a progesterone agonist / antagonist. In other words, depending on where it is in the body, because it gets distributed everywhere, it acts as a mimic or a blocker of progesterone. It turns out it increases some bad things, including breast cancer, by about a 24% increase in breast cancer with the use of medroxyprogesterone acetate. No one should be prescribing that drug for any sort of chronic use. Maybe a brief treatment for a few days, a week, 2 weeks, but not for chronic use as hormone therapy. Now, what about other progesterones? Well, as you know, and I talk about this all the time, the majority of healthcare providers, doctors, nurse practitioners, PAs, are prescribing hormones where they give a very small dose of estrogen, usually estradiol now, not always, unfortunately, but usually, because that's the best estrogen by a long shot. And they will give a little bit of estrogen in the form of estradiol usually, and progesterone, the bioidentical, so that's good. They're not using medroxyprogesterone acetate typically, and they're giving the progesterone every day. Well, I've gone over this. Let me repeat. Progesterone downregulates the receptor function of estrogen. The whole point of doing that is to prevent uterine lining growth so you don't have bleeding. The problem is that's not physiologic. That's not how the female body works. So you're downregulating the benefits of estrogen, which includes many things, including rejuvenation, repair, growth of new tissue. That's all required to be healthy. And all the growth factors are supported by adequate amounts of estradiol. What else does estradiol do that you need to have happen? You need to have programmed cell cycles. So a cell cycle means the cell knows when to rejuvenate and it knows when to die. So there's a process when cells, most cells in the body, get old. We call that senescence. And when cells get really senescent, they develop what is called misfolded proteins that can cause the cell to become a cancer cell. And these old senescent cells also create inflammation. Well, breast cells are supposed to live and die. You would not have the same breast cells that were in your body when you were 25, when you're 55. They come, they're born from your stem cells, they live their life, hopefully, and they're doing the right thing, and then they die when they are old and decrepit, or what we say, senescent. Well, it turns out that estradiol is what we call a senolytic. A senolytic is what everyone is looking for. Drugs, natural or chemically created, that will tell yucky old senescent cells that may develop misfolded proteins, create inflammation, to die. It's called programmed cell suicide or apoptosis. This is largely controlled through mitochondria. We're learning so much more about mitochondria. They create energy, but they also do a lot of cell cycle control. Estradiol has tremendous relationships with mitochondria to help them to do the right thing. So estradiol is very important as a senolytic to tell yucky old senescent cells that could turn into cancer cells to die. It's like, kill yourself, you yucky cell, because you can turn into cancer as well as create inflammation, which underlies so many bad things. So if you are giving progesterone all the time and you give just a tiny dose of estradiol, everything is dose related. You need to have an adequate, a physiologic amount of estradiol, not some pittance. You need to be able to work the cell machinery. You've got to give enough. You've got to create growth factors. You've got to create the ability for the cell to rejuvenate and to die when it should die, not just keep living and then potentially turn into cancer. So you need to have the cyclic nature of progesterone to shed the lining, to allow estradiol to do its job. And you don't want to knock it down all the time with progesterone so that it can't do its job, nor do you want to give such a tiny dose that it won't actually create all the necessary effects, including cell cycle control. There are genes that are triggered by estradiol that are regulated. One of them is PTEN. I call it P10. Now, if you have cancer and you go on Google Scholar or Google and you start looking, the genes are altered. You can't do a study with a cancer cell and then say, see, no, you can't do that. It's like now you're telling what happens with cancer. Genes are expressed differently in cancer. Cancers that are estrogen receptor positive, because that's how they're made, they can hijack estrogen. So it's after the cancer is formed. And that's really important to know that the estrogen did not cause the cancer. but the cancer can hijack estrogen. So what's the goal? Don't get the cancer in the first place by having optimal everything. Diet, sleep, avoidance of chemical endocrine disruptors and other toxicants in the environment, have fitness, have stress control, all the lifestyle things that go into keeping the body healthy, and have optimized hormones, not just some hormones, but optimal physiologic hormones in the right rhythms. So when you look at that study I mentioned that showed estrogen lowers breast cancer risk by up to 37%. The data was kind of all over the place with progesterone. That's because if you give progesterone and you give it all the time, you're lowering the benefits of estrogen because you're negating the optimal function of the receptors. And if you give a really tiny dose of estrogen so that you don't create growth factors, so you don't have bleeding, and then you suppress all those effects with constant progesterone, do you think you're going to get the optimum outcome? The answer is no. So you got to give bioidentical hormones with some semblance to how the body uses them when the body is healthiest. Postmenopausal women who have no estrogen or progesterone production have enormously higher rates of breast cancer than reproductive age women who have normal functioning ovaries and the beautiful rhythmic cycles. Getting into menopause, losing ovarian hormone production is not good. Okay, it's not good. It doesn't lower your risk of breast cancer. It increases your risk of breast cancer. There was a study that was fascinating on uterine cancer, which is another estrogen receptor positive cancer. And in this study in rodents, they injected into the uterus of the rodents estradiol, 17 beta estradiol, the estrogen made by ovaries of every mammal, okay? And they injected the estrogen in the form of estradiol into the uterus, and those rodents had no uterine cancer develop, and the ones they didn't give it, and then they gave them the same like carcinogen exposure, the ones without the estrogen got the cancer. Estrogen helps to cause killing of bad cells, helps to promote restoration, rejuvenation of good cells, and works with the genes to lower the risk, not increase the risk of cancer. The beautiful hormones that we were given were not given to us to give us cancer. So it's so important to understand this, because if you are told in no uncertain terms that you have a family history of breast cancer, so you should avoid going on hormones, run for the hills. That doctor is not keeping up with modern published data, okay? Now, once you have breast cancer, things are different potentially. There's actually no clear data that if you give hormone therapy to a woman who's had breast cancer, that you're going to increase her risk of death. But I'm not going there now, okay? All I want to talk about for now is that if you go on hormones and you take it properly in a rhythm with proper physiologic dosing, you will lower your risk of breast cancer. Now, did I say you will have no risk of breast cancer? Of course, we're not talking about absolutes. We're talking about relative risk. My goal as a doctor, as a medical doctor, an MD, is to do everything I can to optimize the health of my patients. That means I need to give them information that's accurate so they can make their own decisions for their own lives. I'm totally in favor of self-determination, but you can't make a good decision with wrong information, lack of information. Whether you go on hormones or you don't, it's your choice. But don't not go on hormones because you think that not having hormones in your body is going to improve your chances of healthy longevity and avoiding breast cancer. Doesn't work that way. Now, what else can we do? What's the biggest risk factor for postmenopausal breast cancer? It's actually weight gain and obesity, which is fostered by loss of hormones. That's another talk that I'm going to give another day, all about why women gain fat, why they can't maintain proper weight and appetite regulation when they lose their vital life hormones, estradiol and progesterone. But because weight gain is so prevalent and obesity is so common in the United States, where 40% of women now would cross the line and be categorized as obese, that is the biggest risk factor. Definitely not being on hormones, which is not a risk factor, it's a reducing factor. It doesn't negate risk, it just doesn't increase it, and it actually seems to lower it in women based on multiple studies. This wasn't one, this was multiple. These were controlled studies. Estradiol is the best estrogen, but weirdly, any type of estrogen lowered breast cancer risk when they looked at that data. But don't take any kind of estrogen. Take transdermal estradiol if you're going to take hormone therapy in peri or postmenopause. And remember, the women who started hormone therapy the earliest had the highest reduction in breast cancer occurrence. Forget all that nonsense that vital life hormones give women cancer. They don't. That's not how it works. These are vital life hormones. They gave the optimal status of health during the reproductive years. And by doing something like having hormones in a physiologic way, even in the menopausal years, and then adding in all the optimal lifestyle choices, we can't negate the possibility of breast cancer because there are so many things that go on that we can't control, like toxicities and sometimes even stress, even though we can do everything we can. There are things that we can't always control, or things in our past. I mean, there's things we can't control, but there are things we can. Let's do the best we can to lower the risk of breast cancer so that we can optimize our lives. There are many things in this world to be afraid of, but bioidentical, physiologically dosed estradiol and progesterone just should not be on that list. So I hope this helped to clear up this real serious confusion.